Well, hello there, everybody. Welcome back. Today we're going to go over biliary pathology. We'll just get right into it and begin with the gallbladder. The gallbladder is an oblong, pear-shaped structure located on the underside of the liver. It is located at the level of the middle hepatic vein, also known as Cantlie's line, between segments 4 and 5. The normal distended gallbladder is approximately 7 to 10 centimeters in length and 4 centimeters in diameter. The capacity is usually 50 milliliters or 1.8 ounces of bile. The gallbladder is divided into neck, body, and fundus. A pouch in the fundus, known as the Phrygian cap. A pouch in the neck, called Hartmann's pouch. And mucosal projections in the cystic duct, known as the spiral valves of Heister, or Heister's valves. Sonographic appearance is anechoic with an echogenic wall. Increase through transmission is seen posterior to the gallbladder. The gallbladder can be folded on itself in the shape of an S or have folds. The normal gallbladder wall is less than 3 millimeters. Scanning the gallbladder should include right upper quadrant images of the liver, biliary tree, and the gallbladder in sagittal and transverse planes. Things to be aware of are situs inversus and heterotaxy, where the gallbladder can be not where it's supposed to be. It can be found on the opposite side of the body or midline. Agenesis, which is rare and can be associated with biliary atresia and other bile duct anomalies. Also, a gallbladder duplication, which is also rare. An intrahepatic gallbladder can be seen as well, which is a failure of migration during fetal development. A gallbladder that is not bound to its normal location and is covered by visceral peritoneum may exhibit increased motility, which can lead to a volvulus. This is also rare. A contracted gallbladder can give the appearance of a thickened wall, but this is a normal finding and should not be confused for true gallbladder wall thickening. That's why these exams should be performed with at least 6 to 8 hours of fasting. You still can see stones in a contracted gallbladder, but sometimes you can miss some stones that might be in the neck. Another common pitfall is the close proximity of the duodenum to the gallbladder can give the appearance of a stone if the duodenum is filled with shadow causing food. So keep that in mind. Scan the gallbladder in supine, left lateral decubitus for gallstone mobility or to rule out these pitfalls. And you can also scan, I've even scanned the gallbladder upright. Quick story, the gallbladder was one of the first things I scanned in ultrasound school. I think the first thing I scanned was a carotid, which I remember being very excited about. But I remember when we were learning gallbladders, my partner was skinny, so I was like, this is going to be easy. I began scanning with her, and I was, just scanning around her abdomen, looking, and I could not find her gallbladder. I kept on seeing, what was her IVC, but she was so skinny that I thought her IVC for a moment was a gallbladder, but once I put it in longitudinal, you can see that it was a vessel and with color Doppler also. So I asked for the teacher to help. He came around and he immediately was like, oh, she's got gallstones. So she had a gallbladder filled with stones with what we call the wall echo shadow sign. So that was pretty cool. And she was also asymptomatic. All right, so moving on, sludge. Biliary sludge is a very common finding on gallbladder sonography. It is also called biliary sand or microlithiasis. It is mainly comprised of calcium bilirubinate crystals and lesser amounts of cholesterol crystals. It can be asymptomatic. Risk factors are rapid weight loss, gastric surgery, total parenteral nutrition. In fact, you see it quite frequently in ICU patients that are receiving TPN. Some medicines may predispose to sludge, like Rocephin. It is considered a precursor to stone development. In one study, 5 to 15% of patients with sludge went on to develop gallstones. On ultrasound, you'll see low-level echoes to echogenic debris that layers in the dependent part of the gallbladder and is mobile with patient position. Sludge may aggregate into clumps, which may simulate masses or polyps. This is known as tumefactive sludge. In these cases, patient position won't change it, but you can add color Doppler and show that there's no blood flow within the sludge. The gallbladder may also be completely filled with sludge, making the whole gallbladder complex isoechoic to the liver. They call this hepatization. So moving on to gallstones. Cholecystitis. Gallstones typically consist of a mixture of cholesterol, calcium bilirubinate, and calcium carbonate. Gallstones can be found in children, though it is less common. There are even cases of gallstones in utero. Pediatric patients who have hemolytic anemia, such as sickle cell disease or spherocytosis, have an increased risk of developing gallstones, particularly bilirubin stones, from the breakdown of the red blood cells. Risk factors for cholecystitis are obesity, pregnancy, diabetes, gestational diabetes, estrogen therapy, oral contraceptive use, rapid weight loss, hemolytic disorders, and total parenteral nutrition. Sonographically, you're going to see echogenic mobile structures in the gallbladder, which can be solitary or numerous and vary in size from small to large. Stones will have a posterior acoustic shadowing. The gallbladder can be completely filled with stones, obscuring the lumen, leading to the wall echo shadow sign or west sign. Mobility of the stone can be observed by scanning the patient's and left lateral decubitus as well as supine. Scan the intra and extrahepatic biliary tree to look for dilatation, stones, or both. You can categorize cholecystitis into uncomplicated and complicated. Uncomplicated gallstones are asymptomatic patients typically don't require treatment, and stones in this population are often found incidentally, usually while scanning for other things. Biliary colic does develop in about 1 in 5 patients. If biliary colic develops, it is often mild initially. These patients may undergo elective cholecystectomy. A third of patients with 1 episode of biliary colic do not go on to have a recurrence in up to 2 years. And 1 in 5 go on to develop complicated gallstones. Complicated gallstones can be broken down into acute cholecystitis or choledocholitis, pancreatitis, acute cholangitis, gallstone ileus, Meritzi syndrome. That's when the common hepatic duct is obstructed by extrinsic compression from an impacted stone in the gallbladder neck or the cystic duct, and gallbladder cancer. Okay, moving on to cholecystitis. Sudden onset of gallbladder inflammation is a common surgical emergency. The most common cause of cholecystitis is gallstone in the neck or cystic duct. Cholecystitis is gallbladder inflammation. The patient can present with right upper quadrant pain and fever. So fever is kind of give or take. They'll have a distended gallbladder. The gallbladder wall thickness will be greater than 3 millimeters. So there are a few types of cholecystitis. There's acalculous cholecystitis, which represents 10% of all cases of cholecystitis, thought to be caused by gallbladder stasis and ischemia or biliary blockage by sludge. The gallbladder is typically distended with wall thickening greater than 0.3 centimeters or 3 millimeters. There will be pericholecystic fluid and wall edema. Acalculous cholecystitis usually presents in critically ill patients with sepsis and with jaundice without a clear cause. Complications are similar to calculous cholecystitis, including emphysematous cholecystitis, gangrene, and perforation. Gangrenous cholecystitis is considered an evolution of cholecystitis. The incidence of gangrenous cholecystitis ranges from 2% to 30% in all patients with acute cholecystitis. Gangrenous cholecystitis features focal areas of necrosis, bulges of the gallbladder wall, sloughed membranes, and ulcerative craters. Gangrenous cholecystitis can lead to gallbladder wall perforation, which can lead to increased morbidity and mortality due to peritonitis. This condition can be oftentimes indistinguishable from gallbladder empyema, or a pus-filled inflamed gallbladder, or xanthogranulomatous cholecystitis from chronic inflammation. Emphysematous cholecystitis is a form of cholecystitis caused by gas-forming organisms, normally Clostridium or E. coli. It occurs in 1% of cholecystitis cases, but can develop rapidly, leading to perforation and mortality, up to 15 to 20%, 25% of patients. Sonographically, you'll see an inflamed gallbladder with hyperechoic areas in the gallbladder wall, representing gas with reverb, dirty shadowing, or ring down artifact. Okay, on to gallbladder polyps. A gallbladder polyp is a mural lesion that protrudes into the lumen of the gallbladder. Cholesterol polyps are the most common type of polyps. They typically measure less than 10 millimeters and may be solitary or multiple. Sonographically, you'll see an echogenic round lesion adherent to the gallbladder wall, and they will not have shadowing. There are two types, which is benign, cholesterol being the most common. Other types are adenomas, focal adenomyomatosis, and inflammatory hyperplasia. The other types are malignant, which I'll go over in gallbladder carcinoma. Primary sclerosing cholangitis is a risk factor for malignancy in the presence of polyps, especially rapid growing ones, polyps greater than 1 centimeter, segmental mucosal calcifications, anomalous pancreaticobiliary ductal union, or APBDU, patients greater than 50 years of age, and concurrent stones are all risk factors for malignancy. Next up is adenomyomatosis. Adenomyomatosis is a benign condition in the epithelium of the gallbladder wall. There is overgrowth of the mucosa, thickening of the muscular wall, and formation of intramural diverticula known as Rokitansky-Aschoff sinuses. Within these cystic spaces, biliary crystals can get trapped given the sonographic appearance of echogenic foci with comet tail artifacts posteriorly. The changes can be focal or diffuse. Moving on. Calcified gallbladder is known as a porcelain gallbladder, thought to be a calcification from chronic inflammation. On ultrasound, you'll see circumferential increased echogenicity of the gallbladder with shadowing. Porcelain gallbladder can routinely be imaged on radiography or X-ray. Calcification can be focal or diffuse. Originally, it was always treated with cholecystectomy due to a purported high risk of developing gallbladder cancer. However, recent research suggests the incidence is not as high as previously thought. All right, on to gallbladder cancer. Gallbladder carcinoma is the most common biliary tract malignancy, but it is relatively rare overall. They present as primary lesions in 98% of the cases, with 85% of those lesions being adenocarcinomas, and as metastasis in the other 2%, 50% from melanoma, 20% from lymphoma, and the remainder from hepatocellular and renal cell carcinomas. There is increased risk in patients with gallstones and chronic cholecystitis. Sonographically, you'll see a mural lesion extending into the gallbladder lumen, maybe focal thickening or polypoid with a stalk. Color and spectrodoppler may show vascular flow within the mass and stalk. Gallbladder carcinoma is an aggressive cancer, and only 10% of patients present with early stage disease, and those patients are considered surgical candidates. The majority of patients present with advanced disease, with poor prognosis and high recurrence rates. Okay, now on to the biliary pathology. The biliary system is made up of the cystic duct, which comes from the gallbladder neck, meeting with the hepatic duct, or the common hepatic duct, and forming the common bile duct, which travels through the hepatoduodenal ligament to the head of the pancreas, meeting with the pancreatic duct. The terminal end is at the ampulla of Vater in the duodenum. The normal caliber of the common bile duct is less than 7 millimeters with a mean of 3.4 millimeters. Sonographically, it can be imaged at the porta hepatis with the portal triad and be differentiated from the portal vein and hepatic artery by using color Doppler. It can also be imaged at the head of the pancreas, posterior lateral to the gastroduodenal artery. First up on the pathologies are choledochal cysts. Choledochal cyst is a congenital dilatation of the bile ducts. It is more common in East Asian populations. It is most commonly discovered in childhood, though up to 20% can be found in adults. The disease is classified into 5 types. Type 1, which is a fusiform dilatation of the common bile duct, and it is the most common form. Type 2 is a true diverticulum of the bile duct, and it is rare. Type 3, choledochal seals, which is confined to the intraduodenal portion of the common bile duct. Type 4, which is further subdivided into 4A and 4B, are multiple cysts in the intrahepatic and extrahepatic ducts. That's 4A. And 4B is extrahepatic only. Type 5 is Caroli's disease. Caroli's disease is a rare congenital disease of the intrahepatic biliary tree, which leads to non-obstructive saccular or fusiform dilatation of the intrahepatic bile ducts. There's 2 types: Caroli's disease, which is dilatation of the larger ducts, and Caroli's syndrome, which is dilatation of the smaller ducts. It's more common and associated with hepatic fibrosis. Bile duct dilatation can lead to stasis of the bile and sludge stone formation. There is a predisposition to develop ascending cholangitis. It is common in patients with autosomal recessive polycystic kidney disease and can be associated with hepatic fibrosis. Okay, on to biliary atresia. Biliary atresia is a congenital obliteration of the extrahepatic biliary system, which results in a obstruction of bile flow. It is a cause of 1/3 of cases of neonatal cholestatic jaundice. The incidence in the United States is 1 per 10 to 15,000 live births. It is more common in Asian populations. Typical symptoms are jaundice, dark urine, and light stools. Sonography can be used to rule out other causes of jaundice. Occasionally, ultrasound can show an absent or small gallbladder, though that is not always the case, and the triangular cord sign, which represents the fibrous remnant of the extrahepatic bile duct. A HIDA scan is better at evaluating for biliary atresia. Okay, on to choledocholithiasis, or bile duct or common bile duct stones. Choledocholithiasis is the presence of stones in the common bile duct. It's divided into two types. Primary, which is stones that form de novo in the CBD. These are typically brown pigment stones made up of calcium bilirubinate. And secondary, these form in the gallbladder, then move into the common bile duct, and they're most commonly cholesterol stones. Patients may be asymptomatic in up to 50% of cases, or may have symptoms of biliary colic in the right upper quadrant or epigastrium. Other symptoms like pruritus, pale stools, and intermittent jaundice may be present. On sonography, we'll see biliary dilatation. Depending on the location and size of the stone, there may be gallbladder enlargement and intrahepatic biliary dilatation as well. There will be echogenic stones with posterior acoustic shadowing. There may be one stone or multiple. At times, the ductal stones may be too distal to be observed with ultrasound. As such, an ERCP, or endoscopic retrograde cholangiopancreatography, or MRCP, magnetic resonance cholangiopancreatography, may be necessary for diagnosis. Risk factors are sclerosing cholangitis, Caroli's disease, hemolytic anemia, prior biliary surgery, and parasitic infections. Hemobilia and pneumobilia. Hemobilia is blood within the bile ducts and is associated with biliary trauma. It is usually iatrogenic, for example, caused by biopsy or surgery. Other etiologies include cholangitis, vascular malformations, abdominal traumas, and malignancies. The appearance of blood within the biliary tree is similar to blood clots seen in other parts of the body. Often you'll see intraluminal medium level or hyperechoic material. Often you'll see intraluminal medium level echoes or hyperechoic material. More acute thrombus is typically less echogenic. And pneumobilia is air within the biliary system. Also can be a sequela of biliary procedures. It can also be seen with emphysematous cholecystitis. Sonographically, you'll see linear and punctuate echogenic foci with posterior dirty shadowing and ring down artifact. All right, cholangitis refers to inflammation or infection of the CBD or bile ducts. Bile is normally sterile but may become infected due to stasis or obstruction, which encourages the growth of bacteria. Bacteria may ascend into the biliary tree, leading to ascending cholangitis. Anastomosis of the bile duct to the small intestines, such as in a Whipple procedure, may lead to cholangitis. Patients with cholangitis often present with right upper quadrant and epigastric pain, with pain radiating to the right shoulder. Primary sclerosing cholangitis is a chronic inflammatory condition that occurs in the absence of choledocholithiasis or prior bile surgery. It is thought to be autoimmune in origin and is associated with inflammatory bowel disease, Langerhans cell histiocytosis, immunodeficiency, psoriasis, and cystic fibrosis. It tends to be more common in males. Sonographically, there is irregular circumferential thickening of the bile duct walls, luminal narrowing, strictures, and dilatations. Cholangiocarcinoma develops in 7 to 30% of cases. And finally in the series is cholangiocarcinoma. Cholangiocarcinoma or bile duct cancer is a rare tumor that originates in the epithelium of the bile duct. Though it is rare, it is the second most common liver cancer, secondary to hepatocellular carcinoma. Its incidence increases with age, especially after 50 years of age, with peak incidence in the 8th decade of life. Its incidence in the United States is 2.1 to 3 per 100,000 in population. It is classified by anatomical location as intrahepatic, perihilar, and distal. Originally classified as Klatskin tumors, the perihilar cholangiocarcinomas are now classified by the Bismuth-Corlett classification, type 1 being limited to the common hepatic duct below the level of the confluence of the right and left hepatic ducts. Type 2 involves the confluence of the right and left hepatic ducts. Type 3 is subdivided into type 3A, which is type 2 and then extends into the bifurcation of the right hepatic duct. And then type 3B, which is type 2, but instead it goes into the left. Type 4, extending into the bifurcations of both right and left hepatic ducts. Sonographically, the most common findings in patients with cholangiocarcinoma is biliary dilatation. Papillary tumors resemble polypoid intraluminal masses. Nodular cholangiocarcinoma manifests as a discrete smooth mass associated with wall thickening. Infiltrating cholangiocarcinoma is the most common type, but it is difficult to evaluate with sonography. Well, this concludes the biliary pathology section. I hope you found this informative. This will be associated with a blog post that pretty much talks about every single thing I said here. You can find that in sonographictendencies.com. So with that said, take care and goodbye.